Thank you, Professor Ankersmit, for giving me the chance, the privilege to be part of this, as you have seen, exciting project. The task that I've been given for now is to introduce you into the medical problem, the disease that is the target of the forthcoming trial. This is diabetic foot ulcer. This will be, of course, a shifting of gears because we'll become now very medical. And I would be interested how many medical doctors, who is not a physician, who is not a medical doctor in the room? Okay, so a number of non-medical people. So I apologize in the beginning for being, to those of you who are not medical people, for being too medical, and at the same time for my colleagues for being too trivial, because of course rather difficult to find the middle. You might. I personally, I'm a dermatologist. I'm heading the department of dermatology at the University Hospital in St. Pölten, and you might ask how dermatologists come to deal with a problem like diabetic foot ulcer. And there are two main reasons. One is that this is a neglected condition. It's not very famous with medical doctors because it's difficult to treat, and usually in very, very many patients it will be not successful. That's the one reason. And the other reason is historical. This is Charcot, who gave his name to Charcot foot, one of the clinical presentations of diabetic feet. And when he described this disease for the first time, and you see that this feet from the 19th century look essentially identical to what we now see in diabetics, and they had no diabetes at that time, but or in other words, the rate of diabetes in the 19th century was very low, but what was very common at that time was syphilis, and one symptom of late stages of syphilis is neuropathy, so it makes clinically on the feet more or less the same symptoms as diabetic neuropathy does. So the feet look the same, the disease is different, and the pattern of diseases, of course, has changed, and this venereology is a part of dermatology. At least in Europe, dermatologists deal with those patients at that time and deal with those patients today, even if the cause is different. So a few words about diabetes mellitus. I'm not an expert, of course, in diabetes, and there's a lot of literature about the epidemiology of diabetes because this is a massive health problem. You see here from the International Diabetes Foundation the numbers, the patient numbers worldwide with diabetes, and you see that this is a lot. 400 million people, and you see that this is steadily increasing for some reasons or another, where I will not go into detail. And you can ask how about Austria? Data in Austria are incomplete, as with many epidemiological data in Austria, so we do not know too much, but this, you see here what we know from Austria from the same IDF Diabetes Atlas that has been published recently. This is 2017 data, and you see that in Austria the estimated prevalence in the adult populations, not the type 1 diabetes, is 6.4%, and this is more or less very similar to other European countries. It's a little bit different from the United States, where the prevalence is higher, probably depending on lifestyle, of course. And you also see, I think it's on the right here, it costs a lot. So there are a high percentage of our health costs is devoted to the care of diabetes, prevention of diabetic complications, treatment of diabetic complications. And you can read this up in this very interesting and online available report of the International Diabetes Foundation. Now, Austrian data can be also retrieved from this report, and I did this quite recently. And you see the number of diabetics in Austria that we have in thousands. So this would be 600,000 people about with frank diabetes, and about 2/3 probably of persons with imminent diabetes, so impaired glucose tolerance, people on risk of diabetes. So you see that's quite a lot, and it's expected to increase, of course, with time, as you have seen in the diagram before. And it makes a prevalence of about 10% of people with frank diabetes, and 5.6% of the general population who are at risk for diabetes. So this is a very common, big general health problem. And also, it's also important to understand that the problem is age dependent. I also alluded to that before when I showed you when we excluded the younger population, because diabetes, of course, the risk of diabetes increases with age. If you cannot read it, here are the young people, 15 to 29, and these are people above 75, and you see that the prevalence of diabetes increases from almost 0 to 15% in the older population. And as you, of course, all are aware of, our population is generally aging, so the percentage of elderly people increases in the general population, and so does, of course, the diabetes problem. It costs a lot. I already mentioned that, and you also can read about the costs in the Diabetes Atlas in this publication of IDF that I mentioned just a few times before. And you see that in terms of if you make a ranking about countries according to the healthcare expenditure per person with diabetes mellitus, Austria ranks quite on the top. So it's within the top 10 countries, meaning that we particularly take care for the problem already in Austria and spend quite a lot of money for those patients. Whether this is a good sign or a bad sign, I don't know, but it's the case. So why is this? Why is diabetes care so expensive? Because it's not only blood sugar elevation, so it's not only a laboratory problem, but it's a big clinical problem because, as most of you are aware of, diabetes mellitus causes complications, and there is no organ that is spared of that. So any organ system that you can think of can be affected by diabetic complication depending on how long diabetes stands. So it starts with the eyes, with the brain, of course, which is not figured in, and ends up with the feet. The feet are a major target of diabetic complications, particularly in long-standing diabetes. And this is a little bit scary written here. Every 30 seconds, a lower limb or part of a lower limb is amputated somewhere in the world as a consequence of diabetes. So while we sit here, a lot of people have their amputations because of diabetes mellitus complications. So this is a severe condition, can be a severe condition. And now a few scary, one scary images, so a few others will follow towards during the presentation. So this is how the disease looks like. This is, of course, a very advanced stage of diabetic foot, and you can see the wound. And even if you're not a doctor, if you look at this X-ray, you see that this is not a skin problem. Everybody, I think, can appreciate that this doesn't look normal. So it's not the skin surface that's interrupted isolatedly. It's a problem of the whole foot. And you see the skeleton here is completely destroyed, so not even one bone is regular anymore. And you can appreciate that the healing of such a defect seems almost impossible. So this will end most likely in amputation earlier or later. Why is this? So what is the mechanism of this severe complication? How does this come about? And there are two are probably, to be more complete, three major factors. One is neuropathy. If you do this test, the monofilament test, as it's called, on hopefully at least our feet as we're standing here, we would feel a little prick. The diabetic patient feels nothing. This is what called the diabetic patient with neuropathy feels nothing. This is what's called neuropathy. So the sensation on the foot is more or less completely lost. It starts, of course, insidious and ends at a complete loss of any feeling in your feet, which, of course, as you can imagine, you use your feet a lot, might be dangerous because the feedback that you always receive while you walk and while you sit and while you do anything with your feet is gone. And this, of course, increases the risk of injury. And injury is the major initiating event for a diabetic foot or ulcer. And the other critical pathogenetic factor in diabetic foot formation is angiopathy, so ischemia. The feet are at the very end of our circulatory system, so quite a distance away from the from the pump. And it's very important that blood is delivered in a sufficient amount to keep your feet well and alive and bring it, of course, back to the heart. And if you have angiopathy, means vessel narrowing in your vascular system of your legs, then ischemia is the consequence. And ischemia always means a risk of developing a wound and the risk of not healing your wound. So these are the main pathogenetic factors. And in diabetes or in diabetics with foot ulcers, you can calculate that about 50% of those patients have neuropathy and ischemia. So both factors are most commonly associated in most patients. We have also some patients, a third about, who have isolated neuropathy. These patients are a little bit better off because the blood supply is sufficient, and they can, of course, more easily heal their wounds as those patients who eventually will be the victims of or will go into the need for amputation. And we have a very few patients without neuropathy with isolated ischemia, but this is rather rare. I almost never see such patients. So and this is how the disease develops. Here you have a patient, here you have a foot situation that looks rather normal. But if you look more closely, you see a pressure area here, callus, as we call it, thick epidermis. And this is the initial sign of pressure. So the body weight is not correctly delivered to the foot because the foot is already deformed. Foot deformation is the initial, one of the initial signs of neuropathy because you do not feel your feet, and the foot doesn't behave normal, and pressure is not regularly delivered, and the skin reacts with hyperkeratosis, so makes too much hurt. And if you ignore this, as most patients with diabetes do, or many patients with diabetes do, of course, then a wound can develop because this is the site of traumatization. And as soon as the wound develops, the vicious circle starts. Bacteria come into the skin, infection arises, the wound deepens and deepens and deepens, and develops over those stages here to a stage very similar that I have shown you just before. And you can imagine again, if you look at this X-rays, the bone here is completely destroyed again. That this again is very much likely to end up in amputation. And all the targets of our efforts, of course, are to stop the condition here, and or to reverse the condition in a stage where bone is not yet destroyed. So there are a few epidemiological facts about diabetic foot syndrome. It's common in diabetics. The cumulative lifetime incidence of an diabetic individual to develop diabetic foot syndrome is about 25%. That's the estimation. There are certain risk factors, of course, and I think they are self-evident: age, hypertension, smoking, other diabetic complications, and of course the time the patient is diabetic. It's said to be the most serious and most costly complication in diabetes mellitus. It often, too often, results, as I already mentioned, in amputation, which always carries a high risk of mortality. Amputation, of course, is more common in diabetics than in non-diabetics, and it costs a lot. So the care for a patient with diabetes and a diabetic foot ulcer is much higher than the care for a diabetic without that complication. So what to do? That's the question now. So how can we approach this patient? And one of the things is that we have to realize that diabetic foot ulcer is not a single condition. It's part of a syndrome, and the syndrome always involves the whole patient. So what we have to do is not to care only for the wound. We also have to care for the foot, because the general problem, the problem extends from the skin problem, from the local problem, to the organ, to the foot, to the limb, and to the whole patient, of course. And all of those factors have to be addressed when treating diabetic foot ulcer. Here you see diabetic foot ulcer that looks insidious, but if you remove the hyperkeratosis here, you will invariably find an ulcer that might already penetrate to the bone. So the disease might look so less dangerous, but can be already advanced. These are the areas where we can find these ulcers. As I said, there are 3 factors: neuropathy, angiopathy, and trauma. And in a diabetic foot, the sites of trauma are a little bit different from a regular healthy foot, because the foot always has some deformation. And we call this a claw foot. And we call this a Löschwiegen foot. I never found a good translation for this in English. I don't know how it is called in English. But it's similar to a Löschwiege, as you probably see if the Bundespräsident signs his documents. And of course the pressure areas are completely different, either with either this deformation or the other deformation. You can even have pressure sites on the upper side of the foot if you have this claw deformation. Then you can see diabetic ulcers even on the upper side because of pressure from the shoes there. So these are the sites. And this again is how it looks like. And one of the important clues for the medical doctor, what I teach my assistant doctors, is very important to look into the wound, to explore the wound with something stiff, to find out how deep is this wound, does it penetrate to the bone or not, is it painful to the patient or is not painful to the patient, is there infection down there or not. And again, even as a not doctor, you can see that this is a deeply penetrating wound. You find this disturbing, I hope not too much, but you went into this, so it was your choice. You have seen this before? Yeah, what I wanted to show you here is that the bone is visible here. So if you have a clinical eye, then you can see that the bone lies bare on the fascia here. So this is a severe, terrible wound, and one toe has already gone, and the other one probably will not stand for much longer. You have seen this? There are also, and this is probably more the target population for our study, there are also diabetic wounds, diabetics who have neuropathy without angiopathy, or with not too much angiopathy, and those people also develop these wounds. But even if you take an instrument and try to explore to the depths of the wound, you will always find this is superficial. So this is neuropathy without angiopathy. Those patients theoretically can heal their wound. The problem that they have is the metabolic problem, the microangiopathy, so the small blood vessels in the skin are not functioning properly, and of course the continuing pressure, because one of the mainstays of treatment is offloading, and if people don't do that, if they still continue walking on that foot, the wound obviously can never heal. So that's the problem we are tackling with this study. Very similar here, and you see a third of the foot is already gone, and of course everybody wants to keep the big toe here. Here with severe infection, and you see the images are, or the presentation can be rather variable, and therefore it's important to have a classification system, and you will find the classification system more or less the same in the study protocol. And the classification goes from no ulcer to wound penetrating to bone or joint, so it's deeply penetrating wounds, and to without infection or anemia, with infection and with ischemia, because these are the critical concomitant problems: infection and anemia, so ischemia, insufficient blood supply. And you will hear this later on. Our patient population is up here. So patients without infection, without ischemia, because those patients do not need wound care alone. They need, on top of that, systemic antibiotics and some procedures to restore blood flow, either by surgery or by vessel dilation. Now, for the treatment, what can we do? And it's very similar to what I said before about investigation. We have not only to treat the wound, but the whole syndrome. And the whole syndrome, treating the whole syndrome means we have to treat, of course, the patient with his metabolic problems, with socio-economic problems, whatever he might have. We have, of course, to treat the vessel insufficiency, and we have to treat the foot deformation. And the major issue here is offloading, which is also part of the protocol, meaning relieving the foot from pressure. And of course, we have to treat the wound, and I will come to wound treatment later during the day. There are a number of guidelines and recommendations, things like that, around and published, because this is such a problem and nobody exactly knows what to do. And then you take rescue in writing a guideline, and this is just one of those guidelines where I took the treatment options. And when you read those guidelines and you come to wound care, it starts to be confusing. If you read about revascularization, it's quite clear-cut. You operate on the vessels, you make vessel dilatation with balloon catheters and things like that. But if it comes to wound care, evidence seems to be completely gone, and it starts to be confusing. And this is a list, you don't have to read it, what is recommended and not recommended in one more or less randomly selected guideline. And you have to, I at least, and I'm involved with this all the time, I had to read it twice and still found no concept in it, because there is no concept behind it. In one sentence, they tell us, consider topical negative pressure, the very famous VAC treatment. And in the other sentence, they say, no, probably not so good, leave it out. And it continues throughout this. So there is not much evidence. And this is my last slide here. We hope to gain some evidence from the project that we are starting off from now. Thank you. From the clinical project, of course, a lot of preclinical that has been already done. Thank you.